Good morning. This is Faith in Our Hometown, brought to you as a community service and sponsored by Mercy Hospital, Joplin. And now, here's your host, Father Jay Friedel.
Good morning, everyone, and welcome to another Sunday morning of Faith in Our Hometown, our weekly discussion about things that people of faith might be talking about here in our greater Joplin area. We're always pleased that you join us for another Sunday morning, and thanks for joining us on this particular Sunday morning on this nice August day. Or actually, I guess we're still in July. But at any rate, we are going to be talking a little bit about the whole idea of the fact that there were pandemics before the one that we're in now. And one of those pandemics was AIDS. So when I was a young priest, that was the one. When I was in college and grad school and newly ordained, that was the pandemic we were dealing with at that point in time. Everything has changed in terms of some of that, and some things haven't changed at all. And so my guest this morning is going to be from the AIDS Project at the Ozarks, and he is going to be talking with us a little bit about how things have changed. Maybe it'll give us a little bit of perspective on the pandemic we're going through right now. But grab that cup of coffee and stick with us, and we're going to be right back after this Mercy Minute.
Lung cancer is the leading cause of cancer deaths in the U.S., and now we have an effective tool to screen for it. A low-dose CT uses a lower amount of radiation than a standard chest CT.
Breathe in.
Better detailed pictures than a chest x-ray of small abnormal areas of the lung. A person must be between 55 to 77 years old, asymptomatic, which means they don't have any symptoms such as coughing up blood, chronic cough, shortness of breath, unusual weight loss, or any other worrisome symptoms. They must also be a current smoker or have quit within the past 15 years, also must have a 30-pack year history or more, which equates to smoking 1 pack a day for 30 years, or 2 packs a day for 15 years. People generally avoid these scans possibly due to fear of what could be found. Like many other cancers, if we can detect lung cancer early, it could be very treatable and life-saving.
Well, again, thanks for joining us for another Sunday here at Faith in Our Hometown. My guest this morning is Bob Holtkamp, who is as a member of the AIDS Project of the Ozarks. AIDS was something that was a pandemic that hit us a long time ago. So, Bob, why don't you talk a little bit about yourself, talk a little bit about what APO does, and then we'll talk a little bit about what we might think in terms of down the road, what hope we might have in this pandemic for the way things have changed.
Okay, yes, I work for APO, and I work as a community outreach prevention with APO. We've been a long time known as AIDS Project of the Ozarks. That's still, a lot of folks know us. We've shortened our name to APO because we're doing more than working primarily with HIV. That's still our main focus, but we have some hepatitis C and other types of programs that we work with. So we've shortened our name to APO to be more reflective of some of the other things that we're doing.
Right.
Our main office is in Springfield, Missouri at 1636 South Glenstone. We've been very fortunate to move into a new building about 2 or 3 years ago, which is a great state-of-the-art building that contains our case management services programs, the prevention programs, and then our medical clinic. We also have a pharmacy, Grove Pharmacy, that leases space in the front of the building. So that makes it convenient for individuals to seek medical care if they so desire at APO and access their medications. So if you've not been by there sometime, come by and visit us there. Right now, it's a little bit different with the coronavirus.
Sure.
A lot of the health facilities, including APO, have restricted some of the access. So today, the doors are not wide open, so to speak. We ask people to call and make arrangements to come to APO.
Yeah. So, I mean, I remember years ago, back when we were, this is the first time I'd heard the word pandemic, back in 1990, in the late 80s. I was starting to hear about this pandemic that was, AIDS. And, I'm even old enough to know that it went through several name changes at the beginning until we finally settled on something.
Yes.
that we at least could identify that this is kind of what we're talking about. Now, at that point in time, to have AIDS was pretty much a death sentence.
Yes.
You got it, and you knew that you were going to die sooner, much sooner rather than later.
Right.
Because there was no cure.
Right.
Because there was no vaccine. There was nothing there that would prevent a person if they were able to do it. So, a lot of attention on prevention. Okay. And a lot of trying to help people who really very often became pariahs in society because nobody really wanted to deal with them because it was frightening and nobody knew what, can I get it from touching somebody? Can I get it through, breathing? All those things. And so can you take us through, take our viewers through a little bit of that history of how things evolved and to where we're looking at a totally different vantage point today than we were at that point in time.
Yeah, in fact, thank you very much for bringing that up because we typically now, within APO, there is still AIDS diagnosis of individuals that have advanced disease. But in 1995, I'm going to just jump to there,
Sure.
there were introduction of effective therapies, medication called antiretrovirals. Today, we typically call it HIV disease because it doesn't you could be on an early diagnosis, say diagnosed from an exposure from 6 weeks ago, to someone who has more of a complicated case of AIDS. But we roll those up into HIV disease because even with folks who have a more complicated medical history, oftentimes when they are on antiretrovirals, the appropriate therapy, that their immune system can improve, and even though they still have an AIDS diagnosis, we call it HIV disease because their health starts improving over a period of time. So we typically use the phrase HIV disease versus AIDS.
Right.
And that was one of the things why we went to APO also, because we realized as you mentioned, in the early days, one was exposed to HIV and developed AIDS over a period of years, and it was a death sentence. So, but in '95, things started changing.
Things got better. We learned more about the illness and figured out how to, how to keep it from, being such a life shortener at that point in time. Now it's more of a managed care kind of a thing.
Yes, exactly, and it still has its challenges. I don't want to undersell that.
Right.
But if you're in appropriate medical care with a HIV experience treating medical facility physician, there are many medications now that are highly effective that can stabilize one's health and allow them to live a relatively normal life, if you will. I too got involved in working with HIV in the early 90s, and I do share with people that folks that I met in the early 90s are still alive, and they have families, they work, they do they continue to live their life because the medical care has improved so dramatically.
Yeah. Well, I remember dealing with a friend of mine who didn't make it before they had some of those medications, and then I'm still dealing with some of my friends who lived through that first period, and they're still going strong. Health concerns, yes.
Yes.
Because every chronic illness takes its toll on a person after a period of time. But at least now we're not waiting for every moment for them to die the same way we did back in the late 80s and early 90s. Yeah.
Yes, and again, it was due to the early research. We're seeing Dr. Fauci in the news here today about the coronavirus. And Dr. Fauci was with the National Institutes of Health, I believe, at the time. It was also very instrumental in helping getting clinical trials for antiretrovirals approved by the FDA. And that really changed the outcome for a lot of folks. Today, in 1995, in October 95, there were 3 or 4 products that were approved for HIV care, and now there may be as many 30 different products. So prescribing physicians can tailor the medication to that individual and the HIV disease that person is living with, and that has really been a remarkable advance in the last 30 years.
So just thinking back, back again, 90 to 95, a huge change now between 95 and now. So
Yeah.
I guess part of the reason why we're talking about this
Yeah.
this now is to say, we're at the beginning of something new that we don't know what we're dealing with in terms of COVID.
Yeah.
It was the same, in some ways, the same way back many, many years ago that we
Yes.
didn't know what was going to happen, and we didn't know what we were going to find and when we were going to find it and what was going to be effective and all those kinds of things.
Yeah.
But there's reason for some hope because we learn.
Yes, that is exactly right. And really, the study of viruses and virology has improved remarkably over the years. I'll use another example with hepatitis C. Hepatitis C has been the #1 cause of liver transplants in the United States. It's a virus that attacks the liver. Today, they have antiretrovirals for hepatitis C also, so we like to get people diagnosed and get them under medical care. The contrast, though, with HIV versus hepatitis C is that HIV is a manageable disease that you need to take medication daily to manage it. Hepatitis C really is a virus. They've now come out with medications that you can take 8 to 12 weeks and represent a cure or elimination of the virus from that person. So there have been a number of changes, and we hold hope for coronavirus in that same for that same pathway, if we will.
So give us a little bit of a picture. We've been hearing all kinds of statistics and stories about what the picture of the coronavirus looks like right now and where we stand. Where are we standing with this particular, a pandemic that's now, what is that?
I can't.
10, 20, so 30 years, 30 plus years past that. That's, so what kind of a picture do we have now?
Well, I'm just going to give it a little contrast. In the state of Missouri, there's approximately 21,000 people that have been diagnosed with HIV from 1982 to 2017, which is the most current statistics that I've been able to find from the Missouri Department of Health. There were a number of deaths in those early years. About 7,500 individuals have passed away. But today, the death rate, the annual number of people who pass away from HIV has been dropping over the last 10 or 15 years. And when I started in 1992, we were having a number of deaths that went from anywhere from 400 to almost 1,095. In 2017, the number of deaths due to HIV disease was 84. And that's because we've learned to get people into medical care, appropriate care, get them on medication, and then help them with the other struggles: housing, food, transportation, providing a whole package of care for folks that will allow them to continue medical care. Because medical care, in absence of that type of assistance, often have barriers. So we're offering a wide variety of services that we can wrap around, not only at APO, but other agencies, housing agencies and counseling agencies and all that. So if you think about several hundred deaths in early 90s, and now today we have close to 13,000 people living in the state of Missouri with HIV, of which about 1,000 of them live in southwest Missouri, and that's really from Joplin to Rolla down to the Arkansas border, if you will.
Let me stop you there. We're going to take a quick break, and then we're going to come back, and we're going to pick up there. So everybody, we're going to be right back after a real short break here, and we'll be back with Bob Holtkamp from APO.
You're watching Faith in Our Hometown on KSN TV, brought to you as a community service and sponsored by Mercy Hospital, Joplin.
So my guest this morning, Bob Holtkamp from APO, is here talking a little bit about the pandemic that we used to talk about in the 80s, which we now are managing in terms of HIV illness care. and how to do some of those things. So Bob, you were painting the picture that obviously was pretty dire back 30 plus years ago,
Right.
And is a whole lot better today because of the way everything has evolved and we're working with things. So you've talked about some of what the organization does in terms of helping with some of that managed care, and again, eliciting aid from other agencies to assist any of those other things that might be helpful to that person who's going through this.
Yes. And so I want to just continue a little bit of a couple of reasons why maybe besides medical care and the use of antiretrovirals on a day-to-day basis, we actually have some other news that is better news today, if you will. And I'm going to focus a little bit on Southwest Missouri, if you will.
Yeah. I think that'll interest our viewers a little bit more because it's right here at home. Yeah.
Yeah. So in that catchment area of 29 counties that we work in, typically for a number of 7, 8 years ago, we would have, say, 55 to 60 new people that were newly diagnosed with HIV. But there's been two other things that have really led to improvement. And one of them is what we've learned through medical science has learned that if you get into medical care and you're living with HIV and we can connect you up, there's a concept, and you take medication on a regular basis, it will reduce the viral load. Viral load is a measure about how much circulating HIV you have in your blood, and we're starting to hear that a little bit on coronavirus. I heard it today. They talked a little bit about viral loads in clients and individuals, and so you're starting to hear some of that language. So what we want to do now is get people into medical care, get them on the right medication, and what happens is the medication will drive down the viral load. And what's called a U equals U. And if you can get an undetectable viral load of HIV, meaning it cannot be picked up through laboratory testing, it still remains in that person's body because it hides in different places in a person's body. But if we can get you undetectable and you continue to take medication, it becomes untransmittable to your partners. That is a tremendous knowledge and a perspective to really continue the drive on getting people into appropriate medical care early. We still, in Southwest Missouri, we have a little over 1,000 people living with HIV, and we still have probably a couple of hundred people that are not in appropriate medical care and they're not taking medication. We would really love to visit with them and get them in and work with them and get them access to antiretrovirals, work through the insurance, get free medications, whatever we need to do, and help them stabilize their health, and then their partners are protected because it becomes untransmittable. So what's happened is 5, 6, 7 years ago, we typically in Southwest Missouri get 55 to 60 new cases. We're down in the low 30s, 34, 36 individuals. And when I talk numbers, I do recognize each number is a person that has a huge impact. So we've been able to reduce the new infections by almost half by getting people undetectable, which is untransmittable. The second thing that has happened is really from a prevention standpoint. There's 2 antiretrovirals that have been approved for pre-exposure prophylaxis, or PrEP, capital P, small r, big E, big P. And the reason I spell that out is because you can Google this, and there are hundreds of articles and perspectives on PrEP. But it was approved in July of 2012. And what it does is if you're at high risk of acquiring HIV, you can take an oral tablet daily and it prevents you from getting HIV. So 2 things, getting people into medical care and then getting people that have higher risk for PrEP. We are starting to really cut down the number of new cases in Southwest Missouri. And I'm just completely elated with that because, like you, I've spent 30 years, and for 25 of those years, it's been challenging. But we have really started turning a corner now. And what that means is for that individual, they get to continue to live their life and a full life for them. Does that make sense?
Well, it makes perfect sense to me. Now I know there are going to be some folks out there that are, saying, well, prevention, is really the
Yeah.
thing, and we don't want, people shouldn't be doing things that are high risk or
Yeah.
whatever.
Yeah.
What's your response to folks like that when they come and say, "Well, I'm only going to care if I know how somebody got this"?
Well, my perspective is oftentimes we cannot calculate our own risk sometimes, and sometimes our own lifestyle and who we are may put us at risk. And so one category that I'd like to talk about, because it is in Southwest Missouri, is injection drug use. If you're someone is using injection drugs, you may very well share works or needles between a group of people. That is a high probability, if
Sure.
there's one person in there with HIV, high probability of co-infection of partners. We now know that with PrEP, you can also break that transmission by them coming in and getting pre-exposure prophylaxis. And I understand that drug use in that fashion is a very tough,
It's difficult.
very
It's a
difficult
hard
for
thing
the
to deal with.
individual.
Sure. Yeah.
And but we can interrupt the transmission of HIV. So regardless of how that person gets there, we want to encourage people. Obviously, HIV is spread by very close interpersonal relationships, if you will. And we want people, if they want to look at their own risk, it's hard to calculate your own risk. But if you have questions about your sexual activities, injection drug use, we would love to have you come in and visit with us either by phone in this coronavirus world, or come in and get yourself tested, and we can set you up with some prophylaxis or maybe PrEP and help prevent that individual from acquiring disease.
Or from spreading it to somebody else.
Spreading it
Right?
else.
Yeah.
And some of those other things, what we find is like people who come in on a regular basis and get themselves tested, what happens is they start thinking about themselves and others. And I don't know anybody that really wants to spread a HIV infection to a partner, to anyone else in their community.
Right.
And over a period of time, they start looking at their risk. And sometimes they mature and grow, and they may adapt their behavior somewhat through use of prophylaxis, use of PrEP, reducing the number of partners, maybe discontinue injection drug use because they're in therapy, and they can adjust and reduce their risk. So we want to meet the person where they're at. We don't need to say, hey, there's no one way. We want to work with you where you're at, and we want to make sure that you're safe and you have the opportunity for a full life ahead of you. Does that?
Well, I personally, yes. I mean, for me, but again, I sometimes try to make sure that we're having some of that conversation, because I do know that there are a lot of people who are a tough sell. Well, I don't want to care for that person because that person got that in a way that I don't approve of.
Yeah.
And personally, I struggle with that because because I'm like, well, wait a minute. At least the guy I work for would probably care about you first because you're sick,
Yes.
or because you're at risk,
Yeah.
or because you're in danger. Maybe try to get some of the other stuff developed later, in
Right.
terms of, thinking about the common good, or thinking about the people that you're with, or thinking about those other things. But sometimes you got to start with the basic, and the basic is, if you need my assistance and need my help, it making sure that you're okay and that others are okay. Let's start there.
Exactly. That's really one of the foundations for me as an individual why I got involved in this in the early 90s, because I was really convinced in my own mind that if you care for yourself, you're capable of caring for others, and if you care for others, you're caring for your community. And I have had that for 30 years as a kind of an equation for me.
Yeah.
And so we want to take care and help people care for themselves, because we've seen so many examples of people then caring for others and then caring for their community. We're going to start with where we start, and people will grow into that for themselves. We learn as we go in life.
We had a couple minutes here. So is in your statistical knowledge of where this is spreading and who it's spreading to, what are our highest risk groups right now? Again, so the folks, if our viewers know folks, maybe they have a conversation with people. If you talk to somebody perhaps with APO or whatever.
Yeah. So right now we're seeing a little bit of a shift from youth in the ages of 16 to say 27, 28 that are engaging in
unprotected
sex.
Sure.
And let's face it, it's been a few years, but we've all felt a little bulletproof when we were younger. That's just the way life cycles go. And so we're seeing a little bit of shift down into youth being infected at an earlier age. And we're doing a lot of testing with those and prophylaxis distribution. So we're seeing a little bit of a shift in that as far as age versus 30 and 40 years of age. We continue to, about 20% of the individuals are women who have partners who have infected them. We have, and so from a basic standpoint, if you're having sexual relationships with someone, you probably ought to know a little bit about the person.
Right. Yeah, and that gets back to an older. I mean, it gets. I mean, by the time I was, in college, it was just kind of like, never, unless you're protected. That was the message we got, and we got it loud and strong, and that's how we brought some of those things down.
Yeah, so we want people to have the comfort level to talk about their sexual health. I mean, we talk about physical health, mental health, emotional health. Let's get a comfort level of talking about sexual health.
And especially if people are going to be active in those areas, they need to know.
Yeah.
My guest this morning, Bob Holtkamp from APO. We're going to be right back after this Mercy Minute to wrap up.
The whole purpose of screening is to catch people who have a significant smoking history early enough where we can do something about it and potentially improve the duration of life. The minimum recommendation for screening is 30-pack years. So usually people who've smoked more than 30-pack years are the ones that we're screening. If we start screening yearly with low-dose CT scans, we can reduce the risk of death from lung cancer by 20 to 25%. Stage 1, 2, and 3 cancers potentially can be cured. When it becomes stage 4, the possibility of cure falls significantly.
Well, thanks again for being with us this morning. An interesting topic, I think, that, again, won't go away because people are still getting infected and people are still at risk, and people are still living with HIV, which was the first time in my life I used the term pandemic, over 30 years ago, because it was affecting the world. As we talk about these things, we do need to learn how to take care of each other, and I think that's part of the reason, again, why we do the show. So if you know somebody who is not taking good care of themselves or making good choices in terms of their sexual health, maybe to have the conversation with them. If they are not taking good care of themselves in terms of getting into treatment and seeing a doctor and do those things, we need to help take care of each other. That's part of what we do. But I hope that this is a sign that says we've always had these things that will break out in the world, and we've got to figure out ways of working for the common good and helping each other. Thanks for joining us for another Sunday morning on Faith in Our Hometown, and take care of yourself this week and take care of all those around you. God bless.
Thanks for watching. Faith in Our Hometown can be seen Sunday mornings at 6:30 and 9 a.m. on KSN. Brought to you as a community service and sponsored by Mercy Hospital, Joplin.